Thank you for joining us today. I want to welcome everyone to this installment of the STS 2022 webinar series. This series features presentations and panel discussions on a variety of topics relevant and important to cardiothoracic surgeons. The topic today is segmental resection for lung cancer. This webinar is sponsored by Intuitive. Please note this webinar is being recorded and will be available on the STS website and YouTube channel. We invite you to become a member of STS. You'll enjoy a variety of discounts, benefits, and opportunities to help you grow professionally. Learn more at sts.org/membership. At this time, I am pleased to welcome our moderators, Dr. David Rice and Dr. Jason Long. Dr. Rice, welcome. I will now turn it over to you.
Thank you so much, Melissa. And on behalf of my co-moderator, Jason Long, I would like to welcome everybody to this webinar this evening. As you know, segmentectomy and sub-lobar resection has been in the news these days with the recent publication and presentation of two major randomized studies. And so the workforce on general thoracic surgery from the STS thought that it would be an opportune time to make this the topic of one of our webinars. And so we thought that we would do a very brief overview of the current state of the art regarding segmental lung resection. Jason, would you go over the agenda?
Yeah, sure. Thanks, David. And a warm welcome to everyone this evening. Briefly, tonight we're going to have two brief presentations followed by two video presentations. The presentations will include segmentectomy for stage 1A lung cancer, the new standard of care, and this will be by Dr. Nasser Altorki, followed by another 10-minute presentation on advanced imaging for segmental lung resection by Dr. Kazuhiro Yasufuku, and then two video presentations, one of which is from Dr. Abbas E and the other from Mark Dylewski. We will begin first with Dr. Nasser Altorki, who is the Chief of Thoracic Surgery and Professor of Cardiothoracic Surgery at New York Presbyterian and Weill Cornell Medicine. Dr. Altorki, we're very glad to have you. Thank you.
Thank you, David, and thank you, Jason, for asking me to participate in this webinar. You know, I think I'm going to disappoint people. I'm going to talk a little bit about sub-lobar resection. There's also the trials, but not exactly the details of segmental resection. As you know, lobectomy has been the standard of care now for decades, since the 1995 publication of Lung Cancer Study Group, and sub-lobar resection has been relegated, be it a segment or a wedge, to those people who cannot tolerate a lobe. The big news in the last couple of years was JCOG 0802, which is the Japanese randomized trial, which, as you know, randomized 1,100 patients and found superiority of segmentectomy to lobectomy in that cohort of patients. At the same time, we were continuing with the follow-up of CLGB 140503, and that got released by the Data Safety Monitoring Board to us in May of this year. So I'm going to briefly go over both trials. The design of the trial is of the Japanese trial, clinical stage 1A, 2 centimeters or less in size. And the first distinction between the two trials is that lesions that had a GGO component were allowed in this trial. Patients were then intraoperatively randomized to have a lobectomy or an anatomical segmentectomy. And this is the second distinction between that and the American trial, because the American trial allowed both an anatomical segmentectomy and a wedge resection. The primary endpoint of the Japanese trial was overall survival, with a number of secondary endpoints that include recurrence-free survival and differences in respiratory flow rates. The trial recruited 1,100 patients. And as you can see in this slide here, the difference that I alluded to before, which is roughly half the patients in each arm of the trial were entirely solid cancers. The rest had some component of GGO to them. And it's been proposed, I think, with good evidence that a tumor that has a significant GGO component with it is associated with a better prognosis than a totally solid lesion. Be that as it may, the surprise was that segmentectomy was not only non-inferior to lobectomy, but was actually superior to lobectomy in overall survival. In both arms, the 5-year survival exceeded 90% and was 3 percentage points higher in segmentectomy. The p-value for non-inferiority was very significant and very significant for superiority as well. As you can see here, the median follow-up was over 7 years. Relapse-free survival between the two arms was essentially identical, so non-inferiority in that endpoint as well. And for differences in respiratory function, the authors found no difference by the criteria they set up for the trial, which is they wanted to see at least a 10% difference between the segmentectomy arm and the lobectomy arm, favoring the segmentectomy arm to suggest pulmonary preservation. In fact, the difference was less than that, and was although it was statistically significant, it was not clinically meaningful. But paper was published in Lancet, and came to the obvious conclusion that segmentectomy is the standard of care for these group of patients. This just shows you the recurrence patterns, and I would draw your attention to the proportion of local recurrence, which was identical to that reported by the lung cancer study group, 10% in the lobectomy arm and 5% in the 10% in the segmentectomy arm and 5% in the lobectomy arm. So that brings us to our trial, which is another randomized non-inferiority trial. Again, that took patients with suspected or confirmed peripheral non-small cell lung cancers, 2 centimeters or less in size. And then these patients were taken to the operating room and had level 10 and 2 mediastinal nodal stations biopsied. And if they were negative on the frozen section, patients were randomized to a lobar resection or a sub-lobar resection. And here segments and wedges were allowed. And the reason wedges were allowed is because if you look at most of the data in the registries or the other databases, wedge resections are a significant proportion of sub-lobar resection. The primary endpoint was disease-free survival. Secondary endpoints were overall survival and pulmonary function tested differences in expiratory flow rates at 6 months postoperatively. Patients were stratified at inception based on tumor size and cell type and history of smoking. And here you see that there were 697 patients in total were randomized, 357 to the lobar group, 330 to the sub-lobar group, and there are essentially no significant differences between the two arms of the trial in clinical demographic data, but specifically no differences in tumor size, smoking history, or tumor histology. 20% of the patients had other histologies, which are basically large cell, pleomorphic, or neuroendocrine carcinomas, so pretty bad actors. We had published this data before, and I show it just to show you that 80% of patients in each arm had their resection done minimally invasively, whether by VATS or by robotic resection, very low conversion rate, and the 30-day mortality was amazing, 1.1% for lobectomy and 0.6% for sub-lobar resection. So this should put to bed any concern about the often coded 5% mortality rate associated with lobar resection, which is often coded in the non-surgical literature. This is the primary endpoint of the trial. Again, sub-lobar resection, 58% of the patients had wedge resection, 59% had wedge resection. Sub-lobar resection was non-inferior to lobectomy for the primary endpoint of DFS. The stratified hazard ratio was 1.01, and the p-value for non-inferiority was 0.01. So that was significant. And after a median follow-up of 7 years, the 5-year survival was 63% after sub-lobar resection and 64% after lobectomy. When we did an exploratory post hoc analysis of the impact of various variables on DFS in the trial, again, you can see that the dots are right along the unity. So the sub-lobar resection was really non-inferior across all the important clinical and stratification variables. This is the difference between the arms. Again, sub-lobar resection was non-inferior to lobectomy for the secondary endpoint of DFS. The stratified hazard ratio was 0.95, and you can see that the curve for sublobar resection shown here in green starts to edge up a little higher, perhaps tantalizingly similar to the Japanese result. The p-value for non-inferiority was 0.01. Sorry. After a median follow-up of 7 years, 5-year survival after sublobar resection was 80% and 79% after lobectomy. We looked at lung cancer-related events specifically. So in lung cancer-related events were defined as recurrence of lung cancer or death from lung cancer. And they're shown here in the red graph, with the dashed one representing the sublobar and the solid one representing the lobar resection. There's essentially no difference in lung cancer-related events, and no difference between the two arms in competing causes of death. We looked at compared the baseline FEV1% and FVC percent at baseline and at 6 months, and there was a decrement in both values at the 6 months mark. The decrement was higher after lobectomy than sublobar resection, but the absolute difference between the arms, as you can see here, is only 2 percentage points, although that was statistically significant. Again, 2 percentage points for the FVC. So statistically significant, clinically not so meaningful. In the end, we concluded that in patients with peripheral clinical T1A and 0 non-small cell lung cancer without metastasis, and that's a really important point, to major hilar and mediastinal lymph nodes, sublobar resection was not inferior to lobectomy for the primary endpoint of DFS or the secondary endpoint of overall survival. Disease recurrence, which I guess I must have dropped that slide, was observed in 30% of patients. There was no significant difference between the arms in local, regional, or systemic recurrence. I'd add here that local regional recurrence occurred in 10% of the lobectomy arm and 13% of the sublobar resection arm, and that difference was not clinically significant, statistically significant. So a little higher, but not statistically significant. And although the absolute difference in the magnitude of reduction in FV1 and FVC favored the sublobar resection arm, it's not clinically meaningful. The results of this trial and of that of JCOG established sublobar resection, in our case, segmentectomy or lobectomy as the standard, or wedge resection as the standard of care for this subset of patients. And I'll just stop here.
Thank you, Nasser. It really is a tremendous privilege to have you present these results again today. I was curious, you know, the rationale to perform segmentectomy, of course, is less removal of lung and therefore theoretically and potentially an advantage in terms of pulmonary function and potentially longevity. But both your trial as well as the Japanese trial showed only a minuscule difference between 2 to 3%, I think, in both trials. Are we just not measuring it well enough, and specifically for your trial, was there any measurement of quality of life, dyspnea scores, et cetera?
So that's a really important point, and I'm now, as opposed to 15 years ago when this started, convinced that we're looking at the wrong metric. The FEV1 and the FVC are really not the long metric, and functional tests such as the 6-minute walk test, for example, or cardiopulmonary exercise testing, these are the things that we should be looking at. The dyspnea index is a good way to look at it. There's a lot of subjectivity in how you evaluate that, but I think most of us who have done sublobar resection for these patients recognize that there is some meaningful preservation of lung function, and we're just not measuring the right metric for it.
Dr. Altorki, so how do we decide if we should perform a wedge resection versus a segmentectomy? Is there some guidance for that decision?
There's actually no guidance for the decision, and the decision is based entirely on what the surgeon is comfortable with. You know, it's interesting because if you look at the Japanese trial, they've divided their segmentectomies into simple segments and complex segments. So what are simple segments? You do a lingulectomy or a superior segmentectomy. Well, that's easy enough, right? But then you do complex segmentectomies. Now, if you go into take segment 7 or segment 8 or segment 9, not everyone is comfortable doing that. And in fact, even in the hands and really most people would like to do that, at least in Japan, using an open thoracotomy or a mini thoracotomy. And in the Japanese trial, that was a strong predictor of prolonged air leaks and reinsertion of chest tubes. So, one has to wonder whether a wedge resection in a situation in which you would do a complex segment may not be the better approach. The key, of course, is to get a negative margin.
We have time for one quick other question, and Nestor via Mazar asked, Dr. Altorki, how do you explain the difference in survival between the Japanese and the American trial?
Yeah, so that's a good question. I've already alluded to one possibility, which is that 50% of the patients had, part solid adenocarcinoma. But also 20% of our patients, and that's a significant number, had pleomorphic adenocarcinoma, premorphic carcinoma, large cell carcinoma, and neuroendocrine carcinomas. And these are all bad actors that will impact that. I will point out that it's very rare to find disease-free survival reported in the surgical literature. Most of our series report overall survival, and our overall survival is consistent with the reported data.
Perfect. Thank you so much again. Dr. Abbas is a professor of surgery at the Warren Alpert Medical School at Brown University, and is also the chief of thoracic surgery there, as well as being chief of thoracic oncology at Lifespan Health System. And Dr. Abbas, as you all know, also was a co-director of the STS, recently produced STS robotic course. So he's an absolute expert in robotic segmental resection. He's going to talk to us today about a particularly complex redo segmentectomy. Is that right, Abbas?
I'll try, David. Dr. Rice, Dr. Long, thank you so much for the kind invitation to be on the same panel as Dr. Altorki, Dr. Yasufuku, and Dr. Dylewski. It's an honor. I'd just like to share today a video presentation of a segmentectomy and really describe our technique. I have no disclosures. And this was really an interesting case, a 70-year-old female with smoking history who had an enlarging left upper lobe part solid nodule. However, her history, and maybe I'll just stop the video real quick, her history was she had undergone a previous left lower lobe segmentectomy by thoracotomy, and a previous right upper lobe, I believe also a segment in the past for a different cancer. They were all SNR adenocarcinomas, and so she's had 2 previous resections, one of which was by a left thoracotomy on the same side. If you look here at, you see that nodule, it's a question always to me is what segment is it in? We do have our own home-based system. Our radiologists are very interested in segmentation, both in the lung and in the liver, and they use a software called Slicer software. We have a PhD physicist who's also interested in AI, artificial intelligence, and is able to sort of enter the data, and it's very labor intensive, they tell me, but they're able to really identify the structures that I'm looking for. I know there are commercial software, but this is pretty unique. Look at this slice, and you can actually see the shape of the nodule and the surrounding structures. And then I'll go down, they'll show me the artery, the vein, and the bronchus, and everyone was convinced that this was in segment 1. So based on this, and I do this for most of the sort of difficult segmental locations. We went ahead with robotic thoracoscopy. As you can expect, there were some significant adhesions, really everywhere, chest wall, mediastinum, diaphragm, especially on the diaphragm, I always find. And you just take your time. And of course, the nice thing about the robot is you're able to work in a multi-quadrant fashion. And just take your time and complete the lysis of adhesions until you get to familiar anatomy. And so you'll kind of use a combination until you start seeing the anatomy you're used to. Again, this patient had a previous left lower lobe segmentectomy. Here, once we've taken down most of the adhesions, we start our normal hilar dissection and really do what it lends to you. Here we're starting posteriorly, taking the hilar node, station 10 there, and then you find the artery. And you know, as you all know, the left upper lobe, it's sort of like a box of chocolate. You never know exactly the arterial segmentation. But in this case, I was able to kind of review the arteries beforehand, and I knew this patient had a large apical branch, a couple of posterior branches, and then the lingular branches further down. So I know that almost like a right-sided anatomy. So I knew there was going to be a sort of like a truncus branch here serving. And this patient had had a previous, of course, mediastinal nodal dissection. So as you can see, someone's been there before. I'm taking here the AP window node, the station 5, trying to find that that apical branch, that A1 branch. Just take your time. And then that's obviously the vein. So I moved from posterior to superior to anterior, taking my time. Really have to be careful in these redo situations because they've had a previous mediastinal nodal dissection. And so I've identified the upper division vein, and then I identified the intersegmental vein. This vein runs between S1 and S3. As you know, the veins run intersegmentally in that location, and so you take that, and that opens it up nicely behind that to find the A1 artery. Here we're going around it. Be careful, make sure you've dissected out the artery well. And you'll notice, this case I just did a few months ago, you'll notice I use bedside stapling. I think I have better ability to control the guidance of the stapler when I have my two hands, as opposed with robotic stapling, where you're only doing one hand to retract and one hand to staple. It's just a personal preference. I've done robotic stapling also. Once you take that A1 branch, then just below it will be the bronchus. And I'm taking here the lobar lymph node, station 12, left upper lobe, and just in front of it, in front of the bronchus, you'll see the segmental lymph node, station 13 here. And once you take these nodes, that'll expose the bronchus nicely. So as you know, the first division will be lingula and trisegment, or upper division, as it's called. But I want to identify only the B1, which serves the apical segment. Again, just work on the bronchus, separate it from the lymph node, and there you go. That's the bronchus to the apical segment. Complete that segmental node. And here, maybe I do this a little differently, is I don't take the bronchus at this time. I injected indocyanine green, and that very nicely and easily really shows you the demarcation point between the perfused and the non-perfused segment. and I just score it with the back of the bipolar Maryland here. And that just gives me a roadmap to the division. And here I'm taking the parenchyma, not the bronchus. I like to save the bronchus for last. You know, when you take the bronchus first, sometimes it gets included in this parenchymal staple line. So I like to make sure that I have a clean bronchial stump at the end, and I just guide that stapler into the intersegmental plane that I identified with the help of ICG. And as you can see, the bronchus still remains there. This might be the last stapling. And I've really gone to bronchus last on almost all the segmentectomies whenever possible. I just find that it's a cleaner segmentectomy. As you can see, there's the B1 at the end, just like you would do a lobectomy. And just put that in a bag, put a tube, and ensure, especially in these segmentectomies, ensure that, of course, the rest of the lobe comes up well. Otherwise, they can have bad space problems if you have a non-expanded portion of the lobe. And there, and see the X-ray, a little bit of atelectasis from the extensive dissection. And this, again, was another SNR predominant adenocarcinoma. So with that, thank you very much, and happy to take any questions.
Dr. Abbas, thanks for sharing that video. I had a couple questions for you while we're waiting for maybe some more questions from Q&A from the audience. One question is, someone who has a contralateral lung resection prior, have you encountered difficulties with ventilation when you're only ventilating the other lung? I guess that's one question I have. And how do you deal with that? And two is, with this software that you have to visualize the anatomy, do you find navigational bronchoscopy to be helpful? So for me at our institution, we don't have that kind of imaging software, but I find navigational bronchoscopy and marking to be helpful.
Well, thanks, Jason. Great questions. As I'm sure we all experience, if someone had a significant contralateral resection in the past, you can oftentimes manage the patient. Of course, if the patient becomes hypoxic in the middle or hypoventilated, you can stop. You can remove the instruments and allow them to bring up the lungs. Sometimes you do that once or twice. Usually the patient will settle. So, you're working, they tell you, okay, we're hypoxic. They raise the volume on the SAT monitor. So, and then you just stop what you're doing, take out the instruments, have them come up, and then it comes up, you hyperoxygenate, and then you go back to work, and that can buy you time. Navigational bronchoscopy, we actually published on this, is very useful for localization. And I think it's useful not for segmentectomy as much as for a wedge resection. Those are the difficult indeterminate deep nodules. I think navigational bronchoscopy to that nodule with identification any way you want will make it easy to do that wedge. And maybe based on the frozen section, you'll decide whether you proceed to a more anatomical resection.
Thank you, Abbas. There are a couple of questions that I'll try to come back to towards the end of this presentation, but I do need to move along for the sake of time. Thank you. Dr. Dylewski, Dr. Mark Dylewski is from the Miami Cancer Institute, Baptist Health, South Florida, and he will also be presenting a segmentectomy video. Thank you, Mark.
I'd like to thank Dr. Rice and Jason for the opportunity and the STS to give this talk. And Dr. Altorki did a wonderful job at reviewing the literature. So I have some slides in here that will be repeated, and I'll breeze through those very quickly. But I'd like to just bring up some salient points that surgeons have to consider as they address these patients with small peripheral nodules. I have a few disclosures to highlight. At the time when routine CT scan is used in clinical practice and expansion of screening programs are becoming more common, we're finding an increasing number of small indeterminate peripheral nodules, early lung cancers, and both have solid and part solid lesions. Some are pure bronchoalveolar carcinomas, and lobectomy, as we talk here today, it was considered the standard of care, but now it's becoming or increasingly believed that it's an excessive amount of lung resection for these small nodules, especially in the scenario of a number of patients who are diagnosed with early stage lung cancer on these screening CT scans have a high expectation of long-term survival and the possibility of second lung primaries going forward. And so the preservation of lung function becomes more important as we move forward. And I think that, Dr. Altorki's mentioned about you didn't really see an appreciation in improved lung function with the sub-lobar resections compared to the lobar resections, but we know as thoracic surgeons, we are born with a lot of redundant lung tissue. So you're not going to start to see that diminution of lung function until the second or third surgery, similar to Dr. Abbas's surgery that he showed. So we know that GGOs have a better outcome with sub-lobar resections or wedges. There's plenty of meta-analysis and most recently randomized multi-center trials that have demonstrated a benefit to sub-lobar resection. The indications for sub-lobar resections generally are reserved for lesions less than 2 centimeters. And the question arises as to how does the pathology influence whether we choose to do a lobectomy or a sub-lobar resection? And I question the information that Dr. Altorki talked about is, do those individuals that ended up in the other category, have you analyzed how their survival and disease-free survival had been impacted by the sub-lobar resection versus a lobar resection? So the decision to do a wedge resection or an anatomical segmentectomy still remains complex. And I think that you have to take into all those factors before deciding to do a wedge resection versus an anatomical resection. Segmental anatomy, as Abbas pointed out, is very important. And the use of 3D imaging is extremely important. And sub-lobar resections are divided into various elements, not only a wedge resection, but a typical segment, such as a trisegmentectomy or a lingulectomy. But what I'm going to speak about today is the atypical segments, the subsegments of the lobes of the upper, middle, and lower lobe, such as the S1 segment or the S3 segment. And they're defined by anatomical location, as you see here, the anterior apical posterior segment of the upper lobe, or the posterior segment, basilar segment of the lower lobe, or you can also define them based on the bronchial anatomy, which I think if you're going to tackle segmentectomies, especially these atypical segments, you have to be very familiar with the bronchial anatomy, as well as the arterial anatomy and the venous anatomy, especially when there's anatomical variations within the arteries and the veins of the subsegments. And so it's very important to get those 3D imaging to understand the anatomy before you approach these cases. This is just an illustration of the arterial anatomy. The venous anatomy is very variable, and today we're going to be looking at a video doing an S3, S1 segment of the right upper lobe. So technical problems regarding sublobar resections, localizing the small lesions, particularly in the open cases where you have a ground glass lesion, you may not always be able to palpate it, and minimally invasive surgery has made that much more difficult. So you need to be familiar with CT guided localization, navigational bronchoscopy with dye marking, like Dr. Abbas mentioned, and the new fluorescein agents that can be utilized with navigational or robotic bronchoscopy. And really where I find the advantages is with CT imaging with 3D reconstruction, really obviates the need for those other techniques in most cases. Identification of the intersegmental planes is imperative, and there's several techniques that have been developed, such as the individual jet ventilation of subsegments, which is really not real world practice for thoracic surgeons, but the slip top tie technique, which I'll illustrate in the next slide, is useful, and we often use it, or dividing the arteries before the bronchus, which will help demarcate the parenchyma to help guide your division of the intersegmental planes. The fluorescein with respect to the robot is very helpful to define the planes, and then of course CT 3D reconstruction. This is an illustration of the slip knot technique, where you inflate the lung after dividing the bronchus, and then you deflate the lung, or before you divide the bronchus, and then deflate the lung, and the inflated lung that you're planning to remove will remain inflated, and the deflating lung will illustrate the or elicit the demarcation between intersegmental plane. So technical aspects of robotic segmentectomy is similar to a lobectomy, and I've published this in the past, and many of you have seen my presentations. It's a four-arm technique with the anterior arm number 4, where the robotic stapler is placed. This is the outline of the port placements, generally in the 6th or 7th interspace. Here we have a 68-plus-year-old woman with a 1.5 centimeter nodule sandwiched between the S3 segment and the S1 segment of the right upper lobe. Now, I do this, the segmentectomy is a little bit different than Abbas. I find it very challenging to do a segment without dividing the intersegmental planes, particularly when you're dealing with the left upper lobe and the right upper lobe. So particularly when you have an anatomical variations, and you'll see one coming up shortly. Here we divided the oblique fissure posteriorly, and we noticed that there was a very small A1 or A2 artery to the posterior segment of the right upper lobe. So if you weren't aware of that, either based on the CT reconstructions or the intraoperative findings, you may inadvertently divide the A2 artery off the truncus, which we'll see happen here. Here we are developing a plane underneath the horizontal fissure, and then we're easily able to see the V2 and the V3 vein to the posterior segment, and we isolate the V4 and 5 venous branch and the V1 branch and divide it. And then you can see the large A2 artery coming off a very large truncus that you certainly don't want to divide. And then we use the fluorescein to demarcate the intersegmental plane, isolate the bronchus to the S3 and S1 segment, and divide it. So I use this technique similar on the contralateral left upper lobe when I'm doing an S3 segment. I'll divide the lingula away from the trisegment before I divide the bronchus. And oftentimes I'm dealing with an anomalous branch of the lingula, which comes behind the bronchus, which makes it very difficult to do the technique that Dr. Abbas demonstrated in his earlier video. So I prefer to divide the intersegmental planes before I divide all of the arteries in the bronchus. So in conclusion, due to widespread use of CT screening, we're seeing more and more smaller nodule early stage lung cancer in GGOs. Lobectomy for small nodules in GGOs are overly aggressive, in my opinion, given the recent literature. Sub-lobar resections for lesions less than 2 centimeters have been proven to be favorable to lobectomy in many cases, and atypical segmentectomies is a variable treatment option for small tumors with benign disease. Accurate location is very, very important, and I rely heavily on CT reconstruction with three-dimensional anatomy. Thank you very much for the opportunity to speak this evening.
Mark, thank you very much. Fantastic video. Yeah, that recurrent branch that goes to the posterior segment is pretty common. It's like 20 or 30% of the time or something. And you know, you run the risk, if you don't know about that, of either getting into bleeding or devascularizing that posterior segment. What type of 3D segmentation software do you use currently?
Well, we have a variable system that takes a lot of effort to have the radiologist recreate the 3 dimensions. So I don't use it as routinely as many of you all use it, because we haven't come up with a standard practice. But the imaging quality of the CT nowadays, I think, is sufficient to be able to identify the subsegment bronchi and most of the arteries. But that is the main reason why I choose to really expose the anatomy before I start dividing arteries, because I don't always have access to that 3D reconstruction on my cases. And I caution those of you that are going to try to do this minimally invasive. I think robotics is an excellent platform to allow to do this extensive exposure of the anatomy where you don't always have to rely upon the 3D reconstruction. But when you have the 3D reconstruction, it's certainly advantageous.
So we have one question in the chat from Ricardo Terra. So what do you do? And this, I'll open this up to both Abbas and yourself, Mark. What do you do when the nodule is close to the intersegmental plane in your 3D planning? So a very good question. And there's a lot of literature in Asian literature talking about extended segments. And I think this particular case was a perfect example of that. This nodule was sandwiched right between the S3 and the S1 segment. So I chose to do an S3, S1 segment. Fortunately, the S1 bronchus and the S3 bronchus were together. So I didn't have to divide the bronchus individually. But I would caution on doing an extended segment in those situations, because really, I think you need to be careful of the margin. And I think these most recent clinical trials really haven't addressed how much margin we really need, particularly with these high, aggressive malignant, large cell tumors. Those are the ones that are going to fail. Those are the ones that you need to be very careful about. So I think it's very important to get that good margin. How do you feel about that, Abbas?
Totally agree, Mark. Like you said, if there's a question, I'd rather do the adjacent segment rather than just extend the segment. Remember, we're doing these segmentectomies on small tumors or part solid tumors, and it's hard intraoperatively to really determine how much margin you have, like Mark said. So I'd rather, in that case, if it was S1 and S3, I would take them both rather than just extend the one segment.
Well, I think this discussion of variation in anatomy and how we image that ahead of time is a perfect segue to Dr. Yasufuku's talk. Kazu, we're glad you're back online, and we'll let you tell us about advanced imaging for segmental resections.
Thank you very much, and I'm sorry for that technical issue. Hopefully, it'll be okay this time. And so I'll get on with my talk, and so these are my disclosures, nothing related to the talk today. So some of the figures that I will be using in this talk originates from Dr. Takashi Arai's pulmonary resection textbook, and this is considered a Bible for Japanese thoracic surgeons when learning the lung anatomy. Also, Dr. Nomori and Okada have also published a textbook on anatomical segmentectomy. I think is really highly recommended reading for thoracic surgeons when starting complex segmental resections. So as you heard from the speakers, nomenclature and understanding of the segmental anatomy is really very important when planning and performing segmentectomy. Although every segment within the lung have a slightly different anatomy and shape, basically each segment is cone-shaped with the segmental bronchus and artery running into the center. The artery and the bronchus runs along each other, and it does get narrow as it runs to the periphery of the lung. There's usually no artery or bronchus along the intersegmental plane, and the segmental vein runs between the intersegmental plane, which is usually composed of thin, coarse connective tissue. So identifying this intersegmental plane is really the key for performing the successful segmentectomy. And in order to accurately perform these complex segmental resections, accurate knowledge of the bronchial anatomy is really mandatory. And this figure shows the nomenclature of the segmental and subsegmental bronchus. And as surgeons, we need to be able to understand anatomy, especially on bronchoscopy, because intraoperative bronchoscopy, I think, is mandatory when you start doing these segmentectomy. There are variations in the bronchial as well as the vascular anatomy. Since the PA and the bronchus run along each other, the PA anatomy is easier to understand, once you know the bronchial anatomy. However, the pulmonary vein anatomy varies between patients. And since the intersegmental vein defines the border between each segment, the thorough knowledge of the vascular anatomy is really important when performing or planning a complex segmental resection. So with all anatomy put together, surgeons need to understand the 3D anatomy of the segment when planning and performing these segmental resections. The problem is that each patient has some variance, and you're always not given an image like this. So each surgeon will need to confirm the anatomy for each patient. For the variations in the pulmonary artery within the right upper lobe, as much as 20% of the population, 2 arteries rise from the anterior trunk. And when they are present, the recurrent posterior branch is almost always a branch of the truncus anterior superior. And infrequently, more than one ascending branch to the upper lobe arises from the interlobar portion of the artery. For the right middle lobe, at the same level or even either slightly proximal or distal to the posterior ascending artery, the middle lobe artery arises. And the artery is usually single, and bifurcation of the vessel is the rule, but subdivisions are variable. For the right lower lobe, in minority of the patients, the posterior ascending branch to the right upper lobe originates from the right lower lobe superior segmental PA branch. And it's these anatomy that you really need to understand prior to doing a complex segmentectomy. For the left upper lobe PA, this is very variable, and recognizing this remarkable variability is really essential for safely conducting a segmentectomy. For the left lower lobe, the anatomy is also highly variable. So when you start doing the different segments within the lower lobe, you really need to understand all of this. So I think Mark gave detailed technical considerations during segmental resection. So a thorough knowledge of the 3D bronchovascular anatomy is very important, especially identifying the intersegmental vein. And using the transected segmental bronchus as the base of the segmental resection is important when you're dividing the lung parenchyma. Using the intersegmental vein to identify the segmental plane is also important for completing the segmental resection. Now, preoperative planning, I think, is very important. The tumor location and the anatomy of the branches of the bronchus, the PA, and the pulmonary vein is usually defined using the CT scan. There is discussion about adequate margin, and when we are targeting tumors less than 2 centimeters, I believe an adequate margin will be 2 centimeters from the tumor, which will define which segments to resect, as the video was shown. So one of the imaging solutions for preoperative surgical planning is the use of the 3D image analyzer. You can always ask your radiologist to create a 3D anatomy of the bronchovascular anatomy. However, I believe this is not always possible and easy to do routinely. At our hospital, we have been using the Synapse 3D software. This is from Fujifilm, and this is a software that's been used for a very long time, probably over 15 years in Japan. And this video shows the actual preoperative surgical planning using this software. The CD data is imported into the software. First, the lung extraction stage is launched, so it automatically generates this image. The 5 lobes are automatically separated. Next, you proceed to the tumor extraction stage. The tumor is identified on the 2D image. like here, zoomed in and selected, and this will provide volumetric information of the tumor as well as the 3D anatomical information of the bronchus. Then you proceed to the vessel extraction stage. And this usually takes about 20 to 30 seconds. And you can then display the vessels of your interest, whether it's the pulmonary artery or the pulmonary vein or both. And finally, you proceed with the division or region division stage. And this will generate precise anatomy of the lesion of the interest. In this case, this is in the superior segment. And after you select the segmental bronchus, it will then generate post-resection view where you can confirm the surgical margin and distance from the tumor. So I think it's softwares like this that will really help surgeons to understand the anatomy. Just going to skip this a little bit. When performing segmental resection. So this is telling you the segmental plane so that you have enough margin. And this software is very easy to use. And you can have this on your regular hospital computer. So the Synapse 3D has been used in multiple centers in Japan, and this study showed the usefulness of Synapse 3D for preoperative assessment of the pulmonary vessels prior to Abbas lobectomy or segmentectomy. They also looked at short-term surgical outcomes. So as you can see in this image, the software was useful for identification of the vascular anatomy, really not easily detected on the CT scan alone, as you can see here. Now, how do we identify intersegmental plane during surgery? The classical method, as Mark showed, you can use the intersegmental vein, or you can do a ventilation insufflation method. But I think more recently, we have new imaging modality by using ICG and near-infrared imaging. I think most of us use the ICG through an IV injection, but there's a unique way of injecting ICG transbronchially. We all know about the near-infrared imaging, both during VATS or robotic surgery. But this is the transbronchial guidance. So when you're doing complex segments, you identify which segments or subsegments you're going to take. You use the software to identify that. Then you inject ICG transbronchially. And throughout the case, the fluorescence will stay because it's not in the vascular, it's not in the vein. So this is a pretty unique way of identifying the segment or subsegments. In this study, the success rate of the transbronchial ICG injection was about 90%, and the surgical margin simulation versus the actual measurement was very close. So, you know, these are some of the imaging modalities I think that we can use to do a successful segmentectomy. So to summarize, thorough knowledge of the 3D bronchovascular anatomy of the lung is important, and especially identifying the intersegmental vein is very crucial for preoperative planning, especially in complex segmental resection. A high-quality 3D image surgical simulation software is simple to use and very helpful for preoperative planning of anatomical lung resection. And advanced intraoperative image guidance, specifically with the use of ICG with a near-infrared imaging, can assist surgeons for performing these complex resections. So thank you very much, and again, sorry for the technical issues.
Dr. Yasufuku, thank you for an excellent talk. It's quite amazing some of the technological advances you guys are using for segmental anatomy. I have time to maybe read one question from the audience. This is from Ricardo Terra. Great questions to all speakers. Considering part of the veins run in the intersegmental plane and probably drain more than one segment, how do you decide which veins you will ligate?
Should I answer that? So basically, if you are taking one segment, you need to actually identify the intersegmental vein. And it does not matter whether you leave the vein or take it. I usually do not take the vein because if you ligate the vein, you're not going to be able to find the intersegmental plane. That's the key. You need to leave the intersegmental vein and almost like peeling off the lung tissue. I think that's the key of this surgery.
Yeah,
I always edge the stapler on the side of the segment that I'm taking. So, you know, generally you can see where the intersegmental vein goes, and I won't ligate it. I'll put the stapler on the side that I'm taking, similar to my video where you saw the S3, S2 vein. So you certainly don't want to ligate the vein beforehand.
And I think the key is to not ligate, and basically you're exposing the vein as you hold your bronchial stump, and basically if you dissect onto the vein, then that will dissect into the intersegmental vein. And I think the robotic platform is very good for doing that. It's not that easy with the bats, I think.
I agree with you. Dr. Yasufuku, I have a question for you. Your injection of the fluorescein endobronchially, can you do that at the time of the operation, just after you've divided or opened the bronchus? Or do you do that through a bronchoscope?
Yeah, so you do it through a bronchoscope. And the way that it's done, I don't do a lot, but you intubate the patient, you identify the different segments you're going to take. You do a transbronchial injection, and you have to also instill a little bit of air so that the ICG diffuses into the lung parenchyma. And once you do that, the ICG is going to be in the lung parenchyma, so it's not going to fade away.
Is there any regulatory restrictions on endobronchial injection of ICG, Katsu?
Well, I think ICG transparenchymal application, for instance, if you're using it for injection of ICG directly into the lung parenchyma, it's off-label use, and similarly, injecting into the bronchus is also off-label use.
Mm-hmm.
Yeah, and people don't know that.
Well, it's 7 o'clock, and we had planned some case presentations, but in the interest of time, I don't think that we'll be able to probably do that. I do want to really extend a great thank you to all of our fantastic presenters today, and as well as to the STS for putting on this webinar. And just a reminder that it is being recorded, and so if you want to go back and listen to any of this, it'll be on the e-learning center, I think, Melissa, correct?
Correct, and thank you so much for your participation and insight tonight. Thank you so much to the panel.
Thank you.
Thank you.
Have a good evening.
Bye.
We invite you to join us for the next STS webinar on Thursday, September 22nd, as the editorial team of the Annals of Thoracic Surgery discuss publication ethics and the role of research in driving quality and patient safety. We also invite you to register for the STS 59th annual meeting and reconnect with your colleagues in cardiothoracic surgery in San Diego. Sessions will cover the latest research and practice for CT surgical professionals of every discipline and at every career level. Early bird discounts are available until October 13th. Learn more at sts.org/annual meeting.